I almost forgot. So good. So I clicked record now, you guys. So then that way, if you guys have questions, I can put it on the PowerPoint document here that I'm sharing my screen with. So it might be easier for you all to see. Now, before I mention the questions that people were asking in the emails, does anybody have any questions now that you want to make sure we talk about? Because we're here from 9 until 10 today. So we have 1 hour, which is actually not a lot of time because time can sure go by quickly. So if anybody has questions, don't be shy. Type them in the chat bar to your right, and then I will answer them for you. And I do have some questions to go over afterwards and to talk about as well. So I'll give you guys a moment. If you guys have questions, please feel free to type them in the chat bar to your right. And everybody can see my screen, right? I do have it. It says welcome review session. So good. So everybody's saying that they can see my screen. That's excellent. I don't see any questions yet. So what I'll do is I'll go over some of the questions that I had yesterday, that I had the day before, that people weren't too sure about. And I believe it's from a couple different areas. We have some questions on pharmacology. We have some questions on oral pathology. Those seem to be the main ones. So I'm just kind of flipping through my notes here to just see the main questions. Okay, so somebody was asking the difference between a macule and a papule. So this is based on oral pathology, and for those of you who were here yesterday, I think I explained this a little bit, but let me explain it a little more for you guys. And like I said, I'll put it here. So the difference between a macule and papule. So papule, oh my goodness, I am the worst speller ever. So for those of you who are thinking in your heads now, you should be thinking, okay, do I know the difference between a macule and a papule? I hope you do at this point, but I'm going to explain it a little better to you. So a macule is something that is flat, and it's colored. So think of your basic freckle. This is a good example. A papule is different because it is raised. And it could be colored, it could be skin colored. The color is not the huge thing here. It's just a matter of that it is raised. And I guess the same thing with the macule is that it's flat. Let me just underline these for you guys. So this is the clear difference between the two, okay? A papule, what would be a good example? I'd say a mole is a good example. So let me say that here. So a mole is a good example. If you have a papule, does it mean it's going to cause cancer? No. It could be or it could not be. But a papule is a way to basically explain what the lesion looks like. Because when you're looking at a lesion, you want to determine, and I'll put that down too actually. When looking at a lesion, you want to determine the color, the size, and pretty much what it looks like. So what it looks like. So is it smooth? Is it crusted? Is it red with a white center? You know, like these are just some examples. So anytime you're looking at a lesion, and I do this in the dental office too, I will say first sort of what it looks like. Like, is it flat? Is it raised? And of course, how large it is. So is it 2 millimeter by 1 millimeter? Is it 8 millimeter by 8 millimeter? Oh, and you want to say to where it is. So is it on the inside of the cheek? Is it on the outside of the lip? Is it on the face somewhere? Is it on the tongue? You know, things like that. So you want to be specific. And I do this in the office all the time. Let me think of an example for you. Does anybody have questions on how to sort of know the difference between a macule and a papule? And does anybody have any questions kind of how to talk about a lesion? And is anybody confused of the difference between a cancer-causing lesion and a non-cancer causing lesion? So maybe I'll put that here. So if you see that a lesion is benign. This means it's not cancer causing, okay? This is important to note, okay? Because sometimes you might even hear the dentist say, you know, there's a 3 by 3 millimeter papule on the buccal mucosa left side, but it is benign. So if you didn't know what that meant, you might go, what does that mean? I don't understand. But now you know he doesn't think it's cancer causing. But if you hear the word malignant, this is cancer causing. So this is just another way to refer to a lesion, or if he or she's talking about a lesion. So just sort of different ways to talk about it, if that makes any sense. So is everybody good with that so far? Does anybody have questions about the macule and papule? For that person who did ask me that question, does this make more sense to you? Because that is a good question, because once I talk about this, then I kind of think, okay, so let me explain the oral pathology lesions to you, because even in the real world, this is something you need to be looking at. You may be thinking, okay, I don't have time to clean the teeth and to look at the lesions. Well, you don't have to do it as thorough as you did it in school. It's just pretty much having a good look. As you're even cleaning the teeth, you can have a look too. And lesions can be pretty obvious. You know, if you see something out of the ordinary on the tongue as you're cleaning the lower anteriors or something, then it's not like you're taking more time to look for that. It's just something that you will automatically see. So is everybody good though with that so far? I don't see any questions relating to that, so I take that as a good sign. But I do have some other questions here, so let me continue on with that and stop me at any time. So I have a question here. So somebody's asking me to summarize the stains, and that's a good question. So let's talk about stains a little bit here. Okay, so does everybody know the difference between intrinsic and extrinsic stains? Because this is a huge one that they will talk about probably on the board exam. In fact, I know they've talked about extrinsic stains and intrinsic stains before, okay? So as I'm talking about it, as I'm asking the question, you all should be thinking, okay, what do I know about intrinsic and extrinsic stains? So you should be thinking in your head everything you know about that. And if this is something you're a little bit unfamiliar with, there's a great chapter in your Darby and Walsh, and it pretty much talks about stains. It talks about the intraoral exam. It's in that chapter, probably the assessment chapter, because when you assess the stains, that's part of the assessment phase. So you want to see kind of the types of stains they have. So just to talk about it, so intrinsic stains is inside the tooth, and extrinsic stains are outside the tooth. And a good way to remember this is looking at the first part of the word here, so in or ex. Now in, I'd say, is pretty self-explanatory. Intrinsic, in would be inside the tooth. So if this is something that's easily forgotten by you and you're like, I can never remember which is which, this is a good way to look at it. So intrinsic, inside the tooth, and extrinsic, is outside. Some good examples here. So intrinsic stain. So that is stain that's inside the tooth that you can't polish away or the patient can't take off. Now the key about this is if the patient bleaches the teeth, that stain would probably appear less, if that makes sense, because you're pretty much bleaching a good portion of the tooth. And they do say that when you bleach your teeth, it does go inside the tooth a little bit. So, and a good example of an intrinsic stain is, for those of you who may have seen it, you know, if a client's been smoking for 10 years, they have stain on the outside, but then the overall tooth looks kind of a yellowish, brownish color too, right? So that's intrinsic. So, and I do have to tell patients sometimes after I clean their teeth, I do say to them, okay, you have some stain that's outside of the tooth and some that's inside. So if you look at the difference, I did clean away all of the stain that was outside of the tooth. But if stain has been there for a long period of time, or it happened during the development of the teeth, that becomes intrinsic. So it means it's inside the tooth. So does everybody know the differences? So intrinsic is basically from how the teeth developed, or let's say if a patient was giving antibiotics at a young age, then the teeth come in looking kind of a weird color. They don't look normal, for lack of a better word. So intrinsic is more inside the tooth. Or it could just happen where somebody has more yellowish teeth than the average person. That's intrinsic. Extrinsic, of course, is from outside sources. So if you drink coffee, and I'm going to write this down here. So think coffee, you know, tea, smoking, foods, drinks, anything that's an outside source that stains the teeth, that's extrinsic, and that you can take off. Now, that made me think of a question here, and I want you guys to answer this. So what was my question? Shoot, I just lost it. Oh, I know. To remove extrinsic stain, do you want to polish as much as possible first, or do you want to scale the stain off as much as you can first? And they did have a similar question like this on the board exam, so I want to see what you're all thinking. Is it a better idea to sort of polish as much as possible to get that off? Or do you want to use your instruments as much as possible, you know, the best you can before you polish the remaining stain off? Because for those of you who are in school, you've probably noticed that there's just some stain after you scale. You're probably thinking, okay, I know I can take this off easier with the polish, or there's such a tiny amount left that I might as well just polish it off. You know, these things you're probably thinking. But the board exam could ask you a question like this. Do you want to scale as much as possible first, or do you want to think as you're scaling, okay, well, I want to scale, but I know I can polish a lot of this off anyway, so I'm just going to scale a little bit and then polish the rest of the stain. So how do you want to think? So Diane, thank you for answering. So Diane says here you want to scale as much as possible, and this is true. And this is because they actually say that when you polish, you're removing a little bit of the enamel, and you don't ever want to do that. When you scale, you do the same thing, but it's kind of in a different way. It's hard to explain. So what the board exam wants you to think and know is you want to use your instruments as much as possible first. Don't think, okay, I'll clean off the plaque and tartar and then I'll just polish off all of the stain. No, you want to treat stain as just like anything else. So you want to scale that off as much as possible, and then think of stain as the last resort type thing. Because as you polish, you always want to polish selectively, and I'm going to put this down as well. So you want, whoops, I'll put that down as well. So you want to polish selectively, meaning only polish the stain, not enamel. And I'll answer this too. You want to scale as much as possible first. Okay, so does this make sense to everybody? Now, in the real world, however, if you were to only polish the teeth that have stain, which is usually not every single tooth, your patient would probably say to you, were you not cleaning my teeth properly because you only polished like 10 teeth? So in the real world, you polish every tooth. That's just how it is. But on the board exam, they want you to know you don't have to polish every tooth. You only polish the teeth that have stain, because if you're polishing enamel, you're taking off some of the enamel technically, and they don't want you to do that. If you polish stain, you're polishing off the stain, which is good. Another question that I thought about, when you have a patient, let's say, who has heavy stain in some areas and really light stain in other areas, so you might want to use, say, a light prophy paste, a medium prophy paste, and a coarse. Which one would you use first? Would you start with the most coarse first and then finish off with a fine, or would you start with a fine and finish off with a coarse? If you could all answer this, I would really appreciate it because I'm just curious what you're all thinking. Would you start with a coarse paste first and then move to a fine, or how would you do it? I'm curious. How would you do this? And if you see a different answer you don't agree with, that's okay. Pick the answer you would pick because I'm curious. And this actually has been a question on the board exam. Not last time, but I know they had this on my board exam. They had it on the exam a couple years ago. I know they have it on the dental assisting board exam as well. Okay, everybody, so thank you for answering. Okay, perfect. So you would start with the finest one first, because if you think about it, if you start with the coarse paste, that coarse paste will be on your Profi cup. And then if you move to a fine, well, that doesn't really make a difference because that coarse paste will still be on the Profi cup and will still be on the teeth. So you want to start with the finest first because that's not as aggressive. Does everybody understand that? In the real world, you don't use different ones. I mean, I'm just being honest. Who has time for that? We have a medium and we have a fine. We use the fine for children. We use the medium for everybody else, but we wouldn't sort of do different ones because that takes time, and I'm just being honest. But on the board exam, they want you to know to start with the fine first and then the medium and then the coarse if needed. What else did I want to say? Does anybody have any more questions about stain? Because I don't want to sound or, talk about things and you're all thinking, okay, and Andrea, we know this, like move on, move on. So if I'm going too slow, just let me know. I'm talking faster than I normally do because I want to cover a lot of things. Okay, yeah, so somebody's saying, I'm sorry, I don't know how I missed this, but somebody's asking, can we talk about the different colors of stains? Yeah, I don't know why I didn't think about that, so I'm sorry about that, color of stains. Now, can anybody tell me what different colors are there? And I would like you to help me out here. So, yep, black line, let's talk about that. We have orange stain. Any other stains you can all think about here? Because I would like to see what everybody's thinking. Okay, good. So far, so good. Now, can anybody tell me what is significant about black line stain? And this is an excellent question. Thank you. I don't know why I didn't think about this because they like to ask this on the board exam. It's good to know for the real world too. So for black line stain, what is caused by it? Is it hard to take off? Is it easy to take off? Blah, blah, blah. Okay, perfect. Thank you so much. Thank you for answering that. So yes, it's more common in females for whatever reason. And I believe it's too much iron. It's not too little, it's too much iron. And I do see this sometimes. It's very hard to remove, okay? Because often black line stain is very thin. Well, I mean, it could be thick too, but the black line stain that I've seen is very thin, and it's typically on the linguals of the teeth. And if you're a new hygienist, you might be thinking, oh, does this patient smoke? Like, what the heck, right? Oh, and thank you. Usually excellent oral hygiene. So this is where the stain becomes tricky because you might be thinking, okay, this patient brushes and flosses, they have no plaque, they have no tartar, but why is there this black line stain everywhere? And it's usually everywhere. It typically means they have too much iron. They're taking too much. It's more common to have too little iron, but in this case, it could happen from too much iron, or I've heard from certain foods they're eating too. But it's very hard to take off. But the good thing about this, you typically don't have to worry about plaque or tartar because there's not a lot. It's just mainly this black line stain. So that's great to mention. It's good to know for the board exam. Thank you very, very much. And orange stain is usually poor oral hygiene. So that is what happens. And green stain could be from poor oral hygiene. If they're smoking marijuana, that's another big one. Smoking marijuana, how the heck do you guys spell that? I think that's how you spell it. And yes, you make a good point. Thank you. It's usually anteriors. Thank you. I'm happy you had said that. Yes. So usually anteriors. For the orange stain, I don't know if they would be crazy specific about some of these, but it's good to know. So I'm just kind of highlighting the main ones here. For orange stain and green stain, they are both from poor oral hygiene, but if they had them both, orange stain is more commonly from poor oral hygiene because if you think about it, the foods and the drinks you have, there's usually different colors coming with that. So orange means it's just from different sources. So if a patient isn't brushing properly, then you sort of see all of that. It's very, very common, especially in teenagers. Yellow stain, it just sort of happens. Like I get yellow stain over time. So it could mean from plaque, from tartar, you know, just sort of anything. And brown is typically from coffee, tea, smoking, and black, same thing. You know, coffee, tea, smoking. It depends on who the client is. It depends on the bacteria they have in the mouth. It depends on how much they're smoking, how much coffee they're drinking, you know, things like that. I've seen some people who drink 7 cups of coffee a day and have no stain. I see some people who drink 1 cup a day and there's stain everywhere. So it just depends on them. It depends on a lot of different factors. What didn't I want to forget to mention? Oh yes, does everybody remember what this is? Materia alba. This is extremely important. A lot of students mix this up. So now that I'm thinking about stain and poor oral hygiene, if we don't mind just answering this for me. Does everybody remember what materia alba is, how it happens, what it looks like? If you could please answer to the chat bar to your right. I would love to see. So what do you guys think? And then I will answer the rest of the questions, I promise. So materia alba, what is that? Is it plaque? Is it tartar? Is it food? You know, these are the types of things I'm thinking about. If you guys could let me know. And if you're not sure what this is, then this means you do have to study that portion again, the intraoral, extraoral portion. This is something you need to know. Yeah, good. Nadine, that's good. Yeah, so that's true too, Crystal. So let me just say it is from very poor oral hygiene. Like it's not plaque, but it's not plaque. Like it's pretty yucky. How do I say this? It's pretty much like a yellow or even white like cottage cheese-like look. Cottage cheese-like material. It's very thick, and it comes off so easily. Like all they would have to do is take a toothbrush and, you know, go like this, and then it would come off. So that's why this is from very poor oral hygiene. It means they're just simply not brushing their teeth. Oh yes, and it's food also, like it's food particles. It's just yucky. Some students think this is a form of tartar. It's not, because it's very soft and you can take it off with your toothbrush. So let me make a note. You can take it off with your toothbrush. Does everybody understand this? This is extremely important because, actually, you know what? Let me look for a picture. Sorry. Oh no, shoot. I just see that somebody signed up. Oh yeah, I believe they are in here. Okay, anyways. Sorry guys. Let's see. What am I doing here? Materia alba. Let's see. Let's look for... So, ew. Sorry about the pictures, guys, but this is what it is. Oh, that's so small. Okay, this is a really small picture, but this is what it is. because I want you guys to know the difference. Now, ew. Sorry guys, this is really gross. So it's not tartar. It's this white stuff here. Does everybody see that? And again, I am so sorry. This picture is gross. Happy Sunday morning. But this is it. Like, it's a very like white cottage cheese looking material. It happens from poor oral hygiene. It doesn't happen from eating certain foods. It doesn't happen from plaque. It doesn't happen from tartar. It's pretty much before plaque. Like, it's food particles and it's just yucky. So does everybody understand that? I don't see questions, so I take that as a good sign. Okay, so let me go on. There were some other questions here. Sorry, guys, let me move up to the front. Okay. Oh, okay. So Nadine is asking, what color stain does stannous fluoride leave? It's typically like a brown gray stain, stannous fluoride. Usually a brown gray stain. If on the board exam they had one or the other, brown I'd say is the best answer because it's more brown than gray. But again, it does depend on the patient. So that would not be a fair question because if the patient's drinking a lot of coffee and they also have too much of the stannous fluoride, then it could be a different type of color. So I don't like when they ask that because it's not really fair because you need more information, but it's typically like a brown gray stain. It's not a nice color. And that's why they don't use stannous fluoride anymore in the office because it does produce a lot of stain. So I hope that answers your question. I thought there was another question up here, so I'm just kind of looking. So I'll say it again. If I miss a question, please just ask it again, okay? Because I might miss it. Oh, somebody's asking, for stain removal, can you use hydrogen peroxide? Yes, and I have actually done this. So what I do is, let's continue on from this slide because I don't want to confuse anybody. So we'll do stain removal. So yes, you can. I don't know if they would ask this on the board exam because it's just sort of a trick you learn after being in the office for a while, but you can use pumice and hydrogen peroxide to create kind of a paste. And you can use this as your prophy paste. And this actually helps to remove very heavy stain. I have one client or two clients in particular that I'm thinking of. The polishing paste does nothing. Like, it really doesn't remove their heavy stain. So I use pumice and hydrogen peroxide like in a paste, and that seems to help because, as you all know, pumice is coarse, you know, so it does help to remove the stain even more. So that's a good question. And I did have another question, I believe. Oh, maybe not. I think I did answer those questions, I hope. Does anybody have any other questions, or did I miss a question? Because these are all good questions, and I'm sure a lot of students have the same one, so don't be afraid to ask. Oh, okay, and somebody had mentioned, do you scale the green stain? Now, that's very tricky because sometimes you do, sometimes you don't. It depends. So let me tell you. Because in some cases, if you scale off a certain type of stain, and if the layer under that stain is starting to eat away at the enamel, so if that layer is demineralized, for lack of a better word, it starts to eat away the enamel. And if you actually take away that stain, you're opening up the area more, making it worse. I've had this happen once. I have this one client who just has horrible oral hygiene, eats a lot of sugar, mental issues there, but he eats a lot of sugar. And every time I see him, he has like thick plaque on the anteriors, and I don't scale away the stain because if I scale it away, then I am exposing holes in his teeth. So what I do is I polish away the stain and plaque the best I can, but then we need to see him to get a filling or two or, you know, three. So before the dentist fills the teeth, they clean away the stain and then they fix it up. Because if I leave that hole, I guess, there, then it's more exposed. So what I'll put down is, I guess what I should say is if on the board exam it talks about a stain you don't scale off, that would be green stain. So you can't typically scale this off. It depends on the type of green stain. So for the real world, this may not be the case, but if on the board exam, if you're not sure, if it talks about a stain you should not be scaling off, that is green stain. So I'm happy you brought that up because yes, that is true. And next question here. So what is the difference between recurrent and refractory periodontal disease? That's a good question. So recurrent and refractory, and I would like you guys to answer this because I would like to see what your thoughts are. So can you all please, to the best of your knowledge, what is the difference between recurrent and refractory? I have it right here, periodontal disease. What are the differences? Because they are similar. So I would like you guys to see, and I know I have it in my notes here because I did have a similar question with an email question too. And I just want to find what I pulled up here. But what do you guys think? I'm just looking for that. I'm doing a search on my laptop here. Okay, so somebody's saying that refractory does not respond to treatment. Okay, what else? What else do you guys think? I would like to see what you are all thinking, because this is very important. So that's an excellent question. Now, I don't see too many answers. Is this because you're not sure? Or is this because you don't want to have the wrong answer? Don't be afraid of having the wrong answer, because I use this as, if nobody knows the answer, then I need to talk about it further. And somebody's saying that refractory is mainly in young patients and it's very, very aggressive. Okay, so what else? And I'm just kind of looking at my notes here. Sorry, I had this huge note that I had for you guys, and where is it? But so far you are all on the right track, so that's perfect. So keep it up. This is awesome. And yeah, I can't find my notes, which is annoying, but that's okay. So you're on the right track. So let's say refractory, okay? This is when the patient is not responding to treatment. Meaning, if they're coming in every 3 months, they're brushing, they're flossing, but something's not working. This is what this means. So this also means that you may have to say to the patient, for you, the best thing we can do is maintain something. So we don't want to make it worse. We can't seem to get it to get better, but we don't want to make it worse, so we do have to maintain things. So keep on coming in every 3 months so we can do the best we can. I had the perfect example of this. I had a client I will never forget in school. He was 14. He had so much tartar, so much calculus. His gums were so red, but every time I cleaned his teeth, they would look awesome, but then he would come back, he would have the tartar, the plaque, the calculus again. And I saw him like as often as I could, and since I was in school at the time, I could only clean like 4 teeth at a time because there was so much there. And at one point I said to my teacher, I said, I don't feel like I'm even helping him. Like, I feel like I'm not doing anything because every time he comes in, there's more plaque, there's more tartar. The gums are still red, they are still swollen. And she said, you know what, this happens. Sometimes this happens. He has a form of perio that's not going to get better. He may be brushing, he may be flossing, but he needs, there's just something else happening there. So I had to tell him and his father the best thing we can do is to maintain things from getting worse, and hopefully in time things will start to get better. But typically, if a patient's seeing you every 3 months, within 6 months you should start to see quite an improvement. But for this type of client, it could take years. So good question. And recurrent, can somebody tell me what that means? What is recurrent perio? Does anybody know? Because so far you are all doing amazing. So what is recurrent perio? What do you guys think here? Any ideas? And if we're talking about this and you have no clue, then you do know you have to go back to your perio section of your notes and study this again, because this is extremely important. And I'm not getting any answers yet, so I don't know if that's because you don't know or you just don't want to sound stupid, but you have to remember that other students are thinking the same thing, so don't worry about that. Okay, so maybe you guys just aren't sure. So recurrent perio is when the perio keeps on coming back. So how can I say this? The perio comes back, I guess, for lack of a better word. So recurrent perio is when, sorry guys, I'm just trying to think of a good way to explain this. Okay, and somebody's saying, oh, I see. After a period of reduction and then it's reactivated, and then somebody else is saying it is decay that occurs under an existing filling. Now that, I know what you're thinking about. Recurrent decay is different from recurrent perio. So recurrent decay is when, yep, you are absolutely right, when decay happens under or around an existing filling, and I see this a lot. So I see what you were thinking, but that is different from recurrent perio. So let me just put that down here. Different from recurrent perio, but thank you for bringing that up, because a lot of people might have said recurrent decay. I don't know what that means. So now they know. But yes, that's a perfect way of saying it. So the perio comes back. So the perio was treated and they were doing excellent, and the client was doing great, but then they have a relapse. So they might have stopped brushing or flossing or something, might have stopped flossing, let's say, and they missed their 3-month cleaning. So the perio comes back. So this is what that means. Does that make sense? And I do have a question here. Could that be when the client continues smoking? That's a good question. That very well could be the case, but not all the time, because if a client smokes, it doesn't mean they will have perio. They have a much greater chance of getting it. In fact, any client that smokes, I'm pretty sure they have perio, to be honest with you, but I don't know that for sure. It doesn't necessarily mean they'll have it, but it's a much greater chance. So it's quite possible that when you see your client every 3 months, they might have 4 to 5 millimeter pockets. It's possible to say to them, well, as long as you continue smoking, these pockets are not going to go down to 3. Sure, they might, but it's going to take longer, and it's just not as healthy. As soon as you stop smoking, the gums will improve greatly. So that's a good point to bring up. Anytime a client smokes, it's just not good. It's not healthy for them, obviously, and they probably have perio. But yeah, that is a great question. Thank you so much. Thank you for bringing that up. Does everybody understand now the difference between refractory and recurrent? And I want you guys to look through these stages again. If you don't have it, I can send you guys the email. In fact, I think I'll probably do that anyway, because I know that some of you weren't part of the board exam prep course, so you might not have this. So for those of you who did sign up today, I will send you a more condensed version of the different cases of perio, okay? And I want you guys to look through that. It's very, very important, even for the board exam, but for the real world as well. You need to know the differences. Yeah, okay, good. So I believe we got that. And I can't find my notes on it. I did leave some separate notes, but I can't find it, but that's okay. I will send that to you all just to be safe. Just to be safe. Let's see here. And another thing, what did I want to say here? I'm just kind of looking through my notes. Do you guys know the difference between rapidly, I left myself a note here, rapidly progressive perio? What is this? Do you guys know this? Periodontal disease. What is this? Because I find a lot of students get this wrong, so I wanted to talk about it. So since we're talking about perio, this is a good time to talk about it. So what is rapidly progressive periodontal disease? I left myself a note because I didn't want to forget. Is it some teeth are affected, all teeth are affected, happens in the younger age, happens in the older age? What do you think? And if you don't mind typing your answer, I would just like to see what you're all kind of thinking here. What do you guys think? Okay, so some of you are saying that the perio occurs quickly and it's the majority of the teeth. Yes, and it's usually older. Now, that's the tricky case because the age is usually 20s to 30. So it depends if you consider that age old or young. So age 20 to 30. This is usually when it starts, and it happens very quickly, okay? And it usually affects all or most of the teeth, affects the generalized dentition. Okay, and I believe that's all the notes I had. I just wanted to make sure that you guys knew this. So this is a good case of your client comes in, he's 25, and he comes in every 6 months. He normally has good OH. He might have a 4 mm pocket, the 2.6 distal, the 3.7 mesial. He has light to moderate plaque, but you know, nothing significant. And then the next time you see him, it's like, oh wow, your pockets are generalized 5 mm. You still have the same amount of plaque, but why are the pockets so much larger now? This just happens. Sometimes this happens. So when this happens, you need to discuss oral hygiene with them. It's probably a case of, oh yeah, well I normally floss every other day. Lately it's been once a week. Sorry about that, you know. So you need to say, well, they need to start flossing every day, and of course brush at least twice a day, and come in to see you every 3 months, and come for 3-month cleanings until those pockets are under control. So let me put down here. Pockets are, let's even say 5 to 6 millimeters when they are normally 3 millimeters to 4. So this would be pretty significant because as soon as you hit the 5 mm mark, they could be starting to lose the bone support around the tooth, and you never want that. And I do say this to patients a lot. I say, okay, you do have 4 mm pockets. Yes, that's not good. That's not healthy. But is it horrible? No. But what this means is the 4 mm, if you're not starting to brush and floss now, that will become 5 mm, and 5 mm is bad. That's very, very bad. And that's what I tell them. I say it's bad because you could start to lose the bone support around the tooth. The bone is what holds the teeth in. If you start to lose that, it doesn't look nice, it doesn't feel nice, and it could become sore. So that's what I tell them. Does that make sense? Now, when somebody's asking, is this the same as aggressive perio? Yes. So I should say this. Same as aggressive perio. And it's unfortunate because it depends on the textbook. You read. Some call it aggressive perio, some call it rapid progressive perio, some call it rapid perio, some could call it progressive. It's very annoying because I can see why students would get confused and they could say, well, I know what aggressive perio is. What the heck is this rapidly progressive? Is that the same or is that different? So I'm happy you brought that up. Thank you. I apologize for not mentioning that sooner. It just sort of slipped my mind, but it is the same thing. So again, look at your perio. I am going to send you that note when I can find it, and I will look for it. I will send that all to you so you have an idea, okay? Because keep in mind, you need to know the difference between the different cases of gingivitis and perio. Does everybody know what I'm talking about? There's different cases of gingivitis, like plaque-induced, non-plaque-induced, and then you have the perio types. So you need to know that. And somebody's saying, what APA classification does aggressive perio go under? It typically goes under this one, the rapidly progressive periodontal disease. The case number depends on the textbook you read. In fact, I do have my notes here on that, and it actually doesn't have a case number. Oh, wait, sorry, yes, I do. I have it as, it says 4, but I don't agree with that because it depends on the textbook. They really shouldn't ask you the case numbers because that wouldn't be fair. Because it depends on the textbook, it depends on when you graduated. But you know what? I'll see what I have in my notes and I'll send that to you guys too. I'm just kind of looking right now. Yeah, I have it as case number 4, but I know it's 5 in some textbooks, so it could be 4 or 5. But I wouldn't be too concerned about the number, unfortunately, because it would be mean to ask that. But just sort of know what it means. I don't see them saying to you, what is the APA case number 4? What type of perio is that? Because that is silly, and they really shouldn't ask that, so I hope not. But if they do, aggressive perio is 4, it could be 5 in some textbooks. But any other questions, you guys? It's 9:47, so we're almost done. So I know some of you are taking the board exam tomorrow. Good luck. Some of you are taking the board exam on Tuesday, so good luck as well. But make sure to get enough sleep. That's very important. I hate to say it, but study as much as you can today. Study as much as you can tonight, but try to go to bed at a good time so that you're getting sleep because it's going to be hard for you all to sleep. It really, really will. I will say this, when you bring water, it needs to not have a label on it. And as far as I know, it has to be in a clear container so they can tell you have water in it and not alcohol or coffee or something. Who knows, right? But as far as I know, and it depends on who's proctoring the exam. If they're nice people, I'm sure you could bring in a water bottle with a label, but if they're not nice people and they're having a bad day, you need to follow everything to the books. So if you bring a water bottle, don't have a label on it. You can bring paper. You are allowed to bring paper. They may inspect it, but you can bring paper. So if that helps you, make sure to do that. But any other questions, you guys? I'm sure there's other questions, and I will make sure to email you all those perio cases. So if you have questions, ask away. I'm just kind of checking my email now to make sure I didn't miss anybody's questions. I don't think so. I think I answered everything that I wanted to, which is great. And even if you think of a question later, be sure to email me and I will get back to you as quickly as I can. I'm tutoring today until about 6, but I'll have time after that, so definitely let me know. Okay. Somebody's just asking me a private question. At least I don't think that was to everybody, so I will wait for that. Okay, and somebody's saying that they have to leave. That is okay. Oh, and I will have this recording up. I will email it all to you. I do have another session at 10:15, so I don't know. I'm sorry if I can email you all. I may have to wait until 11:30 or 12, but I will get this to you as quickly as I can. But you all did awesome. Thank you for coming on. I hope this helped with any sort of last minute questions. I'm sure every little bit helps at this point. Let me say, if you haven't studied pharmacology a lot, you should be doing that today. And community and oral pathology. It's very, very helpful. If you're confused with anything, I don't mean to sound like a broken record, but please email me. I don't mind. I'm more than happy to help. If I don't get back to you right away, I apologize, but I will tonight because, as you can imagine, there's a lot of students who like to email me last minute. So yeah. And somebody's asking me if I can send you more questions. I'm sorry, I don't see your name on here because it's not giving me your name, so let me know and then I can talk to you about that privately. But if you have any questions, now is the time to answer. Please do. For those of you who took the board exam prep course, you can look through all of those notes once again. So if you're the type of person who's like, I can't read the textbook anymore, like I just can't do it, then read those notes. It's very helpful. For those of you who prefer to look at the textbook, as silly as it sounds, I do suggest you just open up the textbook, just open it, read a certain chapter. That's it. Just sort of read as much as you can. Some things off the top of my head here. Make sure to know the different classes of periodontal disease and gingivitis. Know those. We talked about staining today. That is a great thing to know. Make sure you know the most common types of medications. Like if you're thinking about those seizure medications, know those. Know the different types of seizures. So I'm talking about pharmacology now. Know the different types of seizures. They love to ask that. Know about gingival overgrowth and how to stop that. Does it actually go away? What causes it? Know that. Let me think here. Oral pathology, you do have to know a lot of that because I never know what's going to be on the exam. They tend to ask a little bit of this. They tend to ask a little bit of that. They like to ask things about smoking. They like to ask things about cancer, so know what looks like cancer and what might not look like cancer. We talked about this yesterday, but know the different types of vitamins. So know your nutrition chapter. That is in your Darby and Walsh. They have a great chapter. If you haven't read that, read it today. Know the different cases of vitamins or types of vitamins. Make a chart saying if you don't have enough of the vitamin A, what could this look like? Could it affect the teeth? Could it affect the gums? They like to ask a lot about the patient, if their thyroid is functioning too much or too little. What does that mean? What happens? Let me think here, you guys. They love to ask about special needs clients like heart disease, clients with disabilities. Know how to transfer a patient in a wheelchair. Know the two-person transfer and the one-person transfer. Very important. It's great to know for the real world too. I cannot tell you, I'm a younger dental hygienist. I cannot tell you how many people I have to help with the wheelchair transfer. I'm like 114 pounds. Yet I have dental hygienists who have been there for 30 years and they're like, oh, I'm not sure how and I'm not sure what to do. Can you help me? And I'm kind of like, come on, people. Like I'm a newer dental hygienist. Why are you asking me? You've been here for like 30 years. So you should know that. Know the wheelchair transfer. For your special needs client that can't see well or can't see at all, know how to greet them in the waiting room, know how to talk to them, know how to sort of handle that appointment because it's different. If the client cannot see at all, you would handle things differently. Question, a client who has a service animal. Where do you leave the animal? This is a perfect question. I hope a lot of you are still here. I know a few of you had to leave, but for the client who has a service animal, Where do you put the service animal? This is a great, great question. I'm so happy I heard about it or thought about it. It was on the last exam. So can you guys answer? Because I'm curious what you think, because a lot of students go, oh, good question. Because if you think about it, is it that hygienic to have a dog in the operatory? But do you need to have the dog there because the client relies on that dog every single day? Think about it. Oh, perfect. I'm so happy. So all of you said bring the dog with them. You're absolutely right. Because if you think about it, the client can't see. They rely on this animal every single day. That animal is used to having him or her with them every single day. So if you simply leave the dog in the waiting room, how is that helpful? If you leave the dog in the hallway, how is that helpful? The dog needs to be with the client. So that's perfect. So thank you all for knowing that. That's fantastic. Another one, if a client has a cane or a walker, don't touch that because some clients get quite insulted if you want to help them. And say you try to, after the client has sat down, if you try to sort of take the cane from them to say, move it off to the side to make it easier, don't do that. Some of them get very upset. So on the board exam, always ask them if you can help the client. If the client's in a walker or uses a cane, has trouble walking in some way, don't automatically help them. I mean, as a person, as a human being, you want to, right? But on the board exam, they want you to know you always ask them for help. In the real world too, you'd be surprised. Some clients get very upset if you help them and you're just trying to help them, right? Because it's taking them half an hour to walk down the hall. You'd be happy to help them, but you can't. Just say, what I say is let me know how I can help you. Even a patient who is in a wheelchair, some of them don't want you to help them. In that case, what I do is I will make sure the chair is locked because we do have dental chairs that move. So I make sure to lock the chair. If it takes them half an hour to get into that chair, you just have to let them do it. You can't help them. Some patients don't want you to help them. I have 2 clients that I'm thinking of. They want to do it themselves. They may ask me to move the chair closer to them, but they don't want me to touch their arm, leg, nothing. It's very hard actually. So keep that in mind. Only help them if they want your help. What can I think of? We have 2 minutes left. Other helpful things. AdPi. Let me think about AdPi. Yeah, you pretty much have to know everything. The assessment, diagnosis, planning, implementation, evaluation phase, know it all. Know that you're constantly evaluating though at every appointment. So if you're thinking to yourself, well, the evaluation phase, sorry, I'm just checking if there's any questions. No. Think at the evaluation phase, you're all thinking, well, we would only evaluate at the end because that's the evaluation phase, but not necessarily. You're constantly evaluating at every appointment. So if you had planned that you want the client to see you every 3 months, you want them to start brushing 3 times a week, and then they see you for a cleaning after 3 months, and they're only brushing flossing, and they say they're only flossing once a week. And you say, well, we had planned that you would floss 3 times a week. Why aren't you doing it? They may say, oh, I forgot, or, oh, I didn't want to. So then you have to reevaluate, make things easier for them and change it. Sorry, somebody's asking me, what determines when their recare appointment should be? That's a great question. It depends on the amount of plaque and tartar they have. If they're not flossing, yeah, it really depends on how much plaque and tartar they have and how deep their pockets are. Like if they have generalized pockets of 4 millimeters, they should be coming in every 3 months. If they have one localized pocket of 4 millimeters, 6 months is fine. It depends a lot about that. Look in your notes, because I believe you are part of the board exam prep course. Look in your notes. What unit would that be? Probably the AdPi unit, or even look in your Darby and Walsh. And really, there's probably a chart in there. Study that chart to see sort of what they say. But typically it depends on their pocket depth and how much plaque and tartar they have. So that's a huge point there. And somebody's asking me for the pre-medication questions. I know. I contacted the CDHO. They said that they would email me by tomorrow, yesterday, and they didn't, which is so annoying. So all I can say is do a search online, and I can do that for you too. I believe the Heart and Stroke Foundation typically has your latest pre-medication rules. You should know that. But the rule of thumb is if the client has a knee replacement or a hip replacement, anything being replaced, they need to be on antibiotics, okay, for at least 2 years. If the client has a heart attack, I hope everybody knows this, but if a client has a heart attack, you don't clean their teeth for 6 months. If the client has a stroke, you don't clean their teeth for 6 months. If there's a pacemaker, now this is a tricky one. They don't necessarily need antibiotics, but you should wait 6 months before to have their teeth cleaned. It depends on the surgeon. They might be on antibiotics or they might not. I have some clients that have pacemakers that are on antibiotics for at least 2 years, but then they don't need them. I have other clients who have never been on antibiotics for their pacemaker. I have other clients who they've been on them for the rest of their lives. So let me look that up. That's something that I will email to you guys as well. Okay, I'll look it up myself because I did contact the CDHO to let me know what the new rules are, but they didn't get back to me. So let me go on the Heart and Stroke Foundation because they always have it updated. So that is what you guys should follow. I will email that to you guys. I'm thinking around 11:30 if that's okay, because I do have another session in 10 minutes. So I won't have time, but I'll do it at 11:30 for you guys. Okay, so you all did awesome. Okay, good luck. I'll be thinking about every single one of you. Thank you for coming on today. I do hope this was extremely helpful. Email me. If you need something, email me. A lot of you are on the Dentalelle Tutoring Facebook page. If you have a question, just put it on there because that's very easy for me to answer. I'm in sessions all day today, but it's easy for me to have a quick look on Facebook, see if anybody has questions. So that's always, always easy. You all did amazing. I will send you guys the recording. I apologize. It may not be until 11:30 until after my next session, but I'll do it as fast as I can. So again, thank you so much. Good luck. If you need a pep talk or something, let me know. Just email me. I'd be happy to help. And yeah, I don't see any other questions, so that's fantastic. I will stop this meeting. Good luck. Have fun studying today and make sure to get enough sleep tonight. You all did awesome, okay? Thank you so much, you guys. Bye.